Very good morning to all of you, and good afternoon and good evening to all others who are joining from rest part of the world. Today, our guest speaker for the day is Professor Dr. Andrew Davies from Southampton, UK, and he's going to lecture us on mediastinal large B-cell lymphoma. This webinar is brought to you by Mumbai Hematology Group, supported by INTAS, and very well managed by Perfect Square. I thank Dr. Manoj Kumar and the team INTAS, Mr. Yash, Mr. Kalpesh, and the team Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest for the day, Dr. Riya Balikar from Nagpur, our guest speaker for the day, Professor Dr. Andrew Davies from Southampton, UK, all our discussants who are themselves eminent hematologists and hemato-oncologists, and you participants for sparing your Sunday morning, afternoon, and evening. Let me give a flavor of next weekend activities, that is 11th of November 2023 Saturday, from 7 p.m. onwards, Indian Standard Time. We have a webinar on incorporating immunotherapy and MRD testing in the frontline treatment of adults with ALL by our own guest speaker, Dr. Ryan D. Casade from Seattle, USA. And the next day, that is Sunday, 12th November 2023 from 11:30 a.m. IST onwards, we have a webinar on margin zone lymphoma by our guest speaker, Dr. Shankara Panisha from Birmingham, UK. Let me introduce our discussions for the day, and we have a galaxy of them here displayed in alphabetical order. To start with, we have Dr. V.A. Arun, Surgeon Commander from INHS Aswini, Mumbai, Dr. Asha Shah from Holy Family Hospital and BSES Hospital, Mumbai, Colonel Dr. Ashok Meshram from INHS Aswini, Kolaba, Mumbai, Dr. Asif Iqbal from Dr. Bhubaneswar Barua Cancer Institute, Guwahati, Assam, Dr. Dinesh Sheth from Mangalore Institute of Oncology, Mangaluru, Dr. Gopinathan M. from MGM Healthcare, Chennai, Dr. Hamza Dalal from Fortis Hospital, Mulund, Mumbai, Group Captain Dr. Harshit Khurana from Armed Force Medical College, AFMC, Pune, Dr. Subramanian Kannan from KM Hospital, Pune, Dr. Krishna Rathanam Kannan from Sundaram Medical Foundation, Chennai, Dr. Nishad Dhakate from HCG NCHRI Cancer Center, Nagpur, Dr. Parathan Kurunakaran from Cancer Institute, Adyar, Chennai, Dr. Priyanka Srivastava from Paikaka University, Karamsad, Gujarat, Dr. R. Prasanna from Cancure Cancer Center, Tamil Nadu, Dr. Rajan Yadav from GCRA and BJMC, Ahmedabad, Dr. Rajni Priya Yedla from Mahatma Gandhi Cancer Hospital and Research Institute, Visakhapatnam, Dr. Satyarupa Mohapatra from AIIMS, Bhubaneswar, Dr. Sushil Selvarajan from Christian Medical College, Vellore, and Dr. Urmimala Bhattacharjee from PGI, Chandigarh. Now it's a time to introduce our chief guest for the day. We have with us Dr. Riya Balikar from Nagpur. Dr. Riya Balikar is MD, DM, and DNB Hematology, consultant hematologist and hemato-oncologist at Blood and Heart Clinic, Kingsway Hospital, Wockhardt Hospital, Nagpur. It's my privilege to invite her to inaugurate our webinar and give some words of wisdom. Over to you, Dr. Riya Balikar.
Thank you so much, Dr. Amit. And I would like to thank Dr. M.B. Agarwal, sir, for this honor. First of all, congratulations to Dr. M.B. Agarwal for organizing yet another wonderful webinar, wonderful topics, wonderful faculty. He's been doing it for so many years now. This basically gives us a platform to interact with prominent faculties from all over the world. Like together we have, today we have Professor Andy Davis to enlighten us on this topic of mediastinal lymphomas. Professor M.B. Agarwal has been tirelessly working for the last many years. And like Dr. Amit Khurana just said, it's more than 15 countries. People across 15 countries listen to this webinar and hundreds of delegates every weekend. So regarding today's topic, it's mediastinal B-cell lymphomas. We've come a long way from these lymphomas being clubbed together with the diffuse large B-cell lymphomas to being considered a separate category altogether. And today, Dr. Davis would be shedding more light on this, the advances that have happened as far as the molecular signatures are concerned, the immunophenotyping, the pathogenesis, and how they affect our treatment choice, what advances have happened in the last few years, escalating the treatment, de-escalating the treatment based on the PET responses, role of radiotherapy. This is something that was used left and right for the last many years, but now it's becoming very, very selectively we are using it. It's almost obsolete now. And Dr. Davis would be shedding light on the newer trials that are happening in this field. So thank you very much again for this opportunity, and over to you, Dr. Davis, to start the session.
Thank you so much.
Thank you, Dr. Riya Barika, for that great words of wisdom. Let me share the screen again. Now it's a time to introduce our guest speaker for the day, Professor Dr. Andrew Davis from UK. Dr. Andrew Davis is a professor of hematological oncology in the Faculty of Medicine, University Hospital, Southampton, UK. He specializes in the treatment of malignant lymphoma. His work focuses on translation of biomarkers and novel therapies to the clinical arena. He has extensive experience in early phase trials along with the delivery of practice-changing late phase studies. He is a chair of the UK NCRI Lymphoma Research Group. He is a director of the Southampton Experimental Cancer Medicine Center. He is also regional head and lead for cancers in teenagers and young adults. And he's going to lecture us today on primary mediastinal large B-cell lymphoma. Well, thank you so much. Over to you, Dr. Andrew Davis.
Thank you so much for such a very warm welcome. It's very great to be here today. So my apologies, it's a little early in the morning here in the UK. It's just gone 6 o'clock on a Sunday morning. So I hope I can be bright and perky for you this morning, because I think this is a really interesting topic for us to discuss, and I think we'll have quite a lively discussion at the end of my lecture. So just before I start, I've just got a number of conflicts of interest that I just want to declare to you. I think probably none of these are really quite relevant to the subject, but I want to be absolutely clear. I do a lot of development of novel agents, and therefore we have a lot of interactions with different pharmaceutical houses. So mediastinal lymphoma, primary mediastinal lymphoma, has become firmly cemented as a distinct clinico-pathological entity in our classifications of lymphoma. And we've moved from a provisional entity really to a confirmed entity in the Heme4 2016 WHO classification. And actually in the new two classifications that we have at the moment, the ICC and the WHO Heme5, there's really been no significant change in the definition of primary mediastinal lymphoma. It's a rare entity and accounts for about 2 to 4% of the non-Hodgkin's lymphomas and has a very distinct pattern compared with the other large cell lymphomas. So we obviously recognize the clinical features of this disease. The patients present with a rapidly growing anterior mediastinal mass, and quite frequently we recognize this as an emergency presentation. You know the story, comes in on a Friday afternoon, a young woman with superior vena cava obstruction. Bulk is very common in the presentation. We see a young patient population with a median age of 35 and a significant female predominance. And actually is really quite common in the young adult patient population. Also, we see it within the pediatric patient population as well. And diagnosis comes from the presentation as a result of symptoms, and they're largely compressive symptoms. So things like superior vena cava obstruction, a hoarse voice because of the recurrent laryngeal nerve palsies, often breast swelling, and patients may have presented with a really insidious cough or some chest discomfort. And the CT and the chest X-ray findings, you know, are very familiar to all of us. Now, this is a disease that presents within the thorax with typically invasion of local structures. So we may see pleural involvement, pericardial, chest wall involvement, with associated pericardial and pleural effusions. But it's unusual for us to see disease outside of the thorax. So bone marrow involvement is unusual, and I no longer do a bone marrow on these patients, and any other extrathoracic structures are very uncommon. So this typically presents as a stage 1 or stage 2 disease, and I think that's important because it does change the discriminative value of the IPI in prognosis determining in this group of patients. Now, this is a disease that has trophism for extranodal sites at relapse. So we typically see at relapse involvement of the kidneys, the adrenals, ovaries, and in a small percentage of patients, probably about 3% of patients, we see CNS involvement. And we're not very good at predicting those small numbers of patients who have CNS involvement. The origins of primary mediastinal lymphoma are thymic post-germinal center B cells. And we see that mediastinal lymphoma, primary mediastinal lymphoma, sits in a spectrum between classical Hodgkin's lymphoma and in the middle, mediastinal gray zone lymphomas. And we can see that there is many shared similarities, which I'm going to go on and want to talk to about in my next slide. So making the diagnosis, we need a clear histology sample. Please, there's no role for a fine needle aspiration cytology in the diagnosis. Often it's a little bit difficult to access some of these in deep mediastinal structures where there's a whole range of different critical tissues. But more often than not, using CT or ultrasound guided biopsy, we're able to get sufficient material from a core needle biopsy without having to resort to undergoing mediastinoscopy and all the associated risks that there are in patients who have a mediastinal obstruction when we give them general anesthetic. The pathology of mediastinal lymphoma is that the cells cytomorphologically resemble many other large B cells. These are medium to large sized transformed cells that resemble centroblasts. They have a sort of an abundant pale cytoplasm. There is diffuse architectural involvement. And importantly, we see areas of fine compartmentalizing sclerosis. So it's not the growth sclerosis that we see in NS Hodgkin's lymphoma. It's much finer, and you can hopefully see from that pathological insert, you can see the fine pattern of sclerosis. And of course, it expresses B cell antigens. So we see positivity for CD20, CD79, but lacking surface immunoglobulin expression. As I say, this is a disease of post-thymic B cell, of post-germinal center B cells. So we see evidence of cymatic hypermutation. The CD30 protein is present in about 80% of patients, but unlike Hodgkin's lymphoma, CD30 expression is generally quite weak. We see expression of CD32 in about 3/4 of patients, and then variable expression of both BCL2, BCL6, etc. The MAL protein, myelin and lymphoma-associated protein, which is expressed in the thymus, in thymic medullary cells, is expressed in about 70% of patients and has been sort of thought of as one of those markers to be able to distinguish mediastinal lymphoma. But what I would say is that, the pattern of diagnosis is not based upon one single test, but really based upon the whole clinico-pathological presentation of the patients. Now, how does that compare, as I say, with nodular sclerosing Hodgkin lymphoma and mediastinal gray zone lymphoma, with primary mediastinal lymphoma sitting in the middle? Well, as I say, this is a disease that's predominantly we see in females, whilst mediastinal gray zone lymphoma is more typically in males. It commonly presents with superior vena cava obstruction, which is relatively unusual in Hodgkin's, and sometimes happens in mediastinal gray zone lymphoma. The morphology is just as I have described, and we see an absence of inflammatory cells, whilst in Hodgkin's, well, obviously we recognize there's a copious infiltrate of inflammatory cells. And the sclerosis, as I say, rather than these thick bands that we see in NS Hodgkin's or those focal bands that we see in mediastinal gray zone lymphoma, we see very fine bands of compartmentalizing sclerosis. The immunophenotyping of the disease, as I say, is weak expression of CD30, expression of MAO, and expression of B cell markers. And that changes and is different with non-sclerosing Hodgkin's lymphoma and mediastinal gray zone lymphoma. So particularly MAL expression is very low in NS Hodgkin's lymphoma, whilst it sort of sits somewhere in the middle with mediastinal gray zone lymphoma. And I think that we recognize that mediastinal gray zone lymphoma just sits as its own kind of entity that we're kind of starting to evolve. Now, what about the transcriptional program of primary mediastinal lymphoma? Well, a number of key pieces of work were performed by Lou Stout's group at the NCI and Margaret Shipp's group in the Dana-Farber in Boston, which demonstrated the transcriptional program of primary mediastinal lymphoma was very distinct from other large B-cell or other large cell lymphomas, which I think it really helped to cement this as its own pathological class. And actually the expression profile of primary mediastinal lymphoma was much more akin to those seen in Hodgkin's lymphoma, and particularly within the Reed-Sternberg cell, than it was to other forms of large cell lymphoma. So again, we recognize that the transcriptional program of this disease is very distinct and much more akin to Hodgkin's than the other types of large cell lymphoma, and certainly doesn't fit an ABC or GCB category. When we look at the pattern of genomic aberrations, again, we see it's very distinct from either GC or ABC lymphoma. Down here in the lower panel here, we see the primary mediastinal lymphomas, and primary mediastinal lymphomas are characterized by frequent gains of 2p and 9p. And of course, 9p contains the JAK, the site of the JAK oncogene, and 2p contains the site of the REL oncogene, which is part of the NF-kappa B pathway. There are a few regions of genomic loss, and occasionally we see BCL6 and BCL2 rearrangements, unlike the frequency that we see in diffuse large B-cell lymphoma, NOS. And when we try and tabulate and think about the pattern of genomic aberrations, which we've really begun to understand over recent years, as I say, we see these numbers, these copy number gain changes in certain oncogenes, but we also see a pattern of coding sequence mutations in the STAT pathway, including SOX1, STAT6, and we see coding gene mutations in the NF-kappa B pathway as well. And this story is increasingly becoming relevant as we think about the pathways that are aberrated in the pathogenesis of primary mediastinal lymphoma. And actually, we can see that there are two key aberrated pathways and two pathways of activation that account for the pathophysiology of primary mediastinal lymphoma, and that's aberration in the NF-kappa B signaling pathway, and also aberrations in the JAK-STAT pathway. And the two of these come together to form the kind of the proliferative arm of this disease. What's the evidence for NF-kappa B pathway activation and the finding that there's constitutive activation of this pathway? Well, our gene expression profiling demonstrates overexpression of NF-kappa pathway genes. It's very common. The amplification of the 2p region contains the REL oncogene, which happens in about 70% of patients with primary mediastinal lymphoma, and REL part of the NF-kappa B pathway. We also see inactivating mutations in A20 in just over a third of patients. And this is an important tumor suppressor that switches off the NF-kappa B pathway. And so these are, as I say, inactivating mutations. And what about the JAK-STAT pathway? As I say, we see commonly amplifications in primary mediastinal lymphoma, much more commonly than in other types of B-cell lymphoma, of the 9p24 region where the JAK2 oncogene sits. We also see in our gene expression profiling that there are high levels of various members of the JAK-STAT pathway. These are often overexpressed, and we also see that the suppressor of cytokine signaling SOX1 is often mutated in about 50% of patients. So you can see that we've got these pathways to activation of our malignant B cell. The 9p24 amplicon is obviously very important. We see this, as I say, in about 2/3 of patients, this amplification, because not only does it contain the JAK2 gene, but it also contains the PDL1 and PDL2 genes. And these are surface molecules which are highly expressed in primary mediastinal lymphoma, and clearly you recognize have an inhibitory effect on T cells. And this is important because this is perhaps one of the other reasons we see the pathophysiology of primary mediastinal lymphoma is that there is a degree of immune escape from immune surveillance because of inactivated T cell function, and as a result, this allows an environment for proliferation of the cells. So really, just to summarize what I'd said in terms of our understanding of the pathology of it, through amplification of 9p24, we see increase in JAK2 gene dosing, which results in increased proliferation. We also see increase in PDL1, PDL2 expression on the malignant cells, which results in immune evasion. And both of these are important because these have been considered to be therapeutic targets potentially in this disease. And the third part of that arm is the NF-kappa B pathway. Now, recently, we've seen some exciting sort of unraveling further of the genomic landscape of primary mediastinal lymphoma, and from what have been relatively small studies of whole exome and whole genome sequencing, we've now seen a very large study of over 300 samples of primary mediastinal lymphoma, and to be able to look at the genomic structure of this disease. And some of the lessons are exactly the lessons that I've spoken to you about before in terms of the patterns of recurrent aberrations. But what's been very interesting is that two genes particularly appear to be of significant prognostic value. One of those is CD58, which is a receptor of the CD2 molecule expressed on T cells and NK cells. And mutations in this gene are associated with a significant inferior poor prognosis in patients with primary mediastinal lymphoma. Interestingly, DUSP2, which obviously we recognize in T cell lymphomas, has been identified in the study as being of good prognostic information. And this paper is about to be published, if it hasn't already been published, online in the JCO. Fantastic description of the mutational landscape of primary mediastinal lymphoma. And they think that what we should be doing is looking at mutations in these two genes to help us guide whether we need to consider intensification of our induction immunochemotherapies in these patients or not necessarily. Okay, so a little bit of background then in terms of our enhanced understanding of the molecular pathology of mediastinal lymphoma. Let's move on to some of the important clinical features, which I think are obviously very relevant, and a field that's been full of a lot of uncertainty, but is becoming clearer, I think, to us with new information. So in terms of prognosis of PMBL, I think this is always a very difficult call. I think, as I said to you earlier in my talk, because the fact the IPI is low, it has a low discriminative power to distinguish patients, because the majority of patients are going to be young, so they aren't going to be under 60, so no IPI points. Almost everybody has a high lactate dehydrogenase, and the majority of patients have disease that's confined within the thorax and therefore have low staging. Now, we've seen from some retrospective analysis, not least the British Columbia series, that probably the most important prognostic features are having a performance status that is poor or greater than 1, being older than the age of 40, and presenting with an LDH that is twofold above the upper limits of normal. And I although I don't calculate a scoring system, when I see these patients, I look at these in terms of helping us understand the prognosis of the disorder. Increasingly, we are looking at the value of the PET scan, and the PET scan not only provides us with significant benefit when we're talking about interim and end of induction therapy, which I'm going to go on to talk about in a little bit, but also we can see that it provides us with important information at baseline. And of course, we're increasingly able to calculate a large number of different PET variables to help us understand prognosis. And we've done a study through the International Extranodal Lymphoma Group, where we've looked at a number of PET variables, and actually we found that 2 are particularly of value. And like other large cell lymphomas, the metabolic tumor volume is obviously quite important in terms of determining prognosis, and the total lesional glycolysis again. Now, what we can see when you look at those overall survival and those progression-free survival curves, is that many patients do do very well. And so that discrimination in those patients where we dichotomize some of these PET variables, we see actually that we're not really identifying a particularly poor risk group, but probably total lesional glycolysis is perhaps the most discriminative. I think the key questions when we think about therapy for primary mediastinal lymphoma is that, of course, we've got to get our first therapy right. I think you'll all recognize from treating these patients that most cures come from initial therapy, and that trying to reinduce remission and achieve long-term durable benefit from reinduction therapies and therapies for relapse, etc., unfortunately are relatively disappointing in terms of their outcomes. Our results appear to be, as a general theme, with intensified chemotherapeutic induction schedules better. And we've talked about the potential consolidative role of radiotherapy and how that's probably becoming less important in our treatment approaches now. So really, let's go back to the pre-rituximab era to set the scene. And this is data from Pierluigi Zinzani, who presented a large meta-analysis retrospectively of 400 patients with primary mediastinal lymphoma. And the lesson from this very simple sort of study demonstrated that the outcomes with CHOP chemotherapy, sorry, I don't quite know why I keep advancing, the outcomes with CHOP chemotherapy were inferior to those that could be achieved by using more intensified schedules. And the intensified schedules that were looked at was weekly sequential chemotherapy with MACOP-B and VACOP-B, or indeed with high-dose chemotherapy and peripheral blood progenitor cell rescue. And the message was really quite clear in the pre-rituximab era. Several studies, including the MINT study, looked at the role of rituximab, and this analysis of the patients with primary mediastinal lymphoma from the MINT study that looked at the addition of rituximab to chemotherapy demonstrated two key important factors. One of those is that patients with primary mediastinal lymphoma could generally do very well, but also patients who had rituximab added to their therapies were associated with a significant improvement in outcome. So we can see here in the dark black line where the pointer currently is, that's the outcome for patients with PMBL who are treated with rituximab-based therapy, which I think is very important, but I think you can see that the outcomes are very good. An analysis of the UK 1421 study of some 50 patients with primary mediastinal lymphoma looked at the question, did patients who were treated with R-CHOP chemotherapy do better if the chemotherapy was given on a 14-day schedule rather than a 21-day schedule? And although the numbers in this study are very small, I think they began to they began to kind of open up the question as to whether a 14-day R-CHOP chemotherapy was going to be of significant value to patients. And this demonstrated it in a non-significant way that patients who were treated with R-CHOP 14 had a better outcome than those patients treated with R-CHOP 21. A large retrospective analysis from the LISA group looked at 300 patients with primary mediastinal lymphoma and again confirmed that patients in the modern era treated with R-CHOP 14 or in an intensified schedule with R-ACVP did much better than those patients who were treated with R-CHOP 21. And that's demonstrated, the R-CHOP 21, in the green curve on this graph. Patients treated with ACVBP had a much greater toxicity than those patients treated with R-CHOP 14, and I think we can see in a mounting case based upon retrospective data that we should at least be using R-CHOP 14 in our therapies, and certainly R-CHOP 21 presents an inferior approach for those patients with primary mediastinal lymphoma. So that really moves us on very nicely to the to the data around dose-adjusted EPOCH. You know that dose-adjusted EPOCH is a pharmacokinetically modulated chemotherapy where you change the dose of chemotherapy according to hematological endpoints that are assessed frequently during the delivery of therapy. It's infusional, and adding to the normal drugs of CHOP chemotherapy is infusional etoposide. And data from the NCI published by Kieran Dunleavy, a small group of patients in a phase 2 study demonstrated excellent outcomes in terms of event-free survival and overall survival. And dose-adjusted EPOCH regimen has not included radiotherapy. Now, of course, you know, patients who go to the NCI in the States, I've worked there myself, you know, obviously that generally they are proactive about finding trials, and they are proactive about getting on airplanes to go and have treatment. And I don't quite believe that the patients that were in that study initially were perhaps representative of all the patients who perhaps walk in outdoor with primary mediastinal lymphoma. But we've seen a number of retrospective data sets. This data set includes children, which are shown in the black line under the age of 21, and those older than the age of 21 shown in the blue lines. Again, they show excellent outcomes. Only about 16% of these patients received radiotherapy, but perhaps the outcomes are not quite as good as we had seen in the initial analysis. And I think when we think about dose-adjusted EPOCH, there are some key questions that we need to think about in terms of the long-term toxicity. Of course, we're giving significant doses of anthracycline, and I think we have to think about what the long-term impact of the escalation of the doxorubicin is on patients' hearts when they are in young adulthood. Most of the patients are receiving greater than 500 milligrams per meter squared of doxorubicin. And also we have to think about the impact potentially on these significant doses of cyclophosphamide on long-term gonadal function. Although I will say that Kieran has published some data to demonstrate that there have been successful pregnancy outcomes in patients who've previously been treated with dose-adjusted EPOCH. Further retrospective data, this is from 144 patients who we compared dose-adjusted EPOCH in the blue to R-CHOP chemotherapy, demonstrates that overall survival and progression-free survival were similar, but the hazard ratio for dose-adjusted EPOCH was in favor of the more intensified regimen, but this was not statistically significant. What we will say is that it was interesting that dose escalation was much harder in a real-world patient population than it has been reported through the NCI, that very many of these patients in this retrospective study, in fact 60% of patients received consolidative radiotherapy, and the toxicity of dose-adjusted EPOCH is really very much higher than it is of conventional R-CHOP chemotherapy, with greater degrees of neutropenic sepsis and greater degrees of hospitalization. So after induction immunochemotherapy, we can see that very many patients are left with a residual mediastinal mass. And that's largely because of this component of compartmentalizing sclerosis that we see. And because there was frequently a residual mediastinal mass, many schedules had included radiotherapy, and we'd seen really excellent outcomes with patients with induction immunochemotherapy followed by radiotherapy. And therefore, there's been a significant vogue to consolidate patients with radiotherapy on completion of induction immunochemotherapy. And of course, this is important because we are treating a residual kind of mediastinal mass. The data to support radiotherapy in the modern era is perhaps limited. We can see from a retrospective study that the addition of radiotherapy may be associated with a small difference in overall survival. Sorry, there's no difference in overall survival, but small difference in progression-free survival. And because of the data from the dose-adjusted EPOCH over the years, there's been a significant decline in the proportion of patients who have been receiving involved field radiotherapy, but data from the SEER registry over a similar period of time demonstrates what's seen to be an 11% absolute survival benefit from radiotherapy. So here we are, we've got a dose-adjusted EPOCH regimen that doesn't use radiotherapy. We've seen some data to support the use of radiotherapy, and we're suddenly in this situation to ask, what is the role in the modern era of radiotherapy in this disease where we get one chance to cure our patients? So we conducted a large international collaborative study, the ILSG 37 study, to ask the question, in the modern era with immunochemotherapy and PET scans, what is the role of consolidative radiotherapy in this group of patients? The design of the study was very simple. Patients had a permissive range of induction immunochemotherapies. They could have R-CHOP 21, 14, MACOP-B, VACOP-B, dose-adjusted EPOCH. And at the end of treatment, about 6 weeks after they've completed induction therapy, they had a PET scan. And if the PET scan had a Deauville score of 1 to 3, where we declare them to be in a complete metabolic remission, i.e. the uptake is below that of the liver, patients were randomized either to have observation or to have mediastinal radiotherapy, which 30 gray, which started in about 8 weeks of completion of immunochemotherapy. Patients who had a Deauville score of 4 or 5, where uptake was greater than the liver, those patients came off study, and patients were treated according to the investigator's choice, and we collected data about the treatment that they had, but there was no protocol-defined treatment. The reason we use the Deauville score of 3 as a cutoff is based upon some retrospective data we collected through the ILSG 26 study, demonstrating that those patients in a CMR defined by a Deauville score of 1 to 3, i.e. the maximal lesional uptake sits somewhere between the mediastinum and the liver, shown in the blue line, did much better than those patients in the yellow line, where the Deauville score was greater than 3, and hence our decision for the cutoff. Now, we calculated that we needed to enroll about 550 patients, and we expected to randomize about 268 patients, which we did in this study. We randomized 136 patients to radiotherapy and 132 patients to observation. Now, the stats of this study are important because we had a pre-planned sample size of 376 patients, so more than we've presented to you there. And that's because we had to think quite hard about how we took this study forward, because the event rate was much lower than we had expected it to be. In fact, we saw the number of scans that were PETs negative was different to what we had expected, and therefore we had to kind of ask an interim analysis, and the rate of failure of patients was much less than we'd also expected. So we actually, based upon the event rate that we were seeing in the modern era, it was actually calculated that we'd need over 3,500 patients to get the number of events that we were needed. So the study I would present to you is when we have had follow-up of pretty much all patients for some 30 months, but perhaps less than we had wanted to demonstrate in terms of a non-inferiority study. So, as I say, 136 patients had radiotherapy, 132 patients were observed, and the demographic profile of these patients is very similar to what we would expect it to be in a population of patients with mediastinal lymphoma. We see that about 2/3 of patients present with bulky disease, and you can see that the majority of patients, 2/3 of them, are female, with a median age of 35, exactly as we had predicted from our understanding of the demographics of the disease. Our patients had a range of different induction therapies. We can see that about 20% of patients had dose-adjusted EPOCH, and about 25% of patients had R-CHOP 14, with about 20% of patients treated with R-CHOP 21. The majority of patients had a outcome PET scan of Deauville score 2 or Deauville score 3, it's quite difficult because there's a heterogeneous uptake to make a Deauville score 1 in these patient populations. So here's the primary endpoint of the study. We can see that 30-month progression-free survival in the red line for patients with radiotherapy treatment was 98.5%, compared with observation, which is in the blue line, which is 96.2%. So essentially, these patients have a really excellent outcome if you have PET negativity at the end of induction therapy, and that you can safely say that there's no role for consolidative radiotherapy for this group of patients. When we look at the overall survival, we can see that overall survival for both groups have completely overlying curves, which is 99% overall survival at some 30 months. And these are really very impressive results, demonstrating what excellent outcomes can be achieved with optimal therapy for this group of patients. Now, we can see that there are a number of significant and severe cardiac adverse events and second malignancies, and all of these occurred in the patients that received consolidative radiotherapy. Now, some of these second malignancies, we can't at all to say that they are related to the radiotherapy, things like melanomas outside of the radiotherapy field or glioblastoma, but certainly I think, we worry about cardiac events. We certainly see all the significant cardiac events in those patients who were treated with radiotherapy. Now, what happened to those patients who were off study, who scored a Deauville score 4 or 5? Well, actually, those patients who had a Deauville score 4 had an excellent outcome as well, interestingly enough. There are about 170 of these patients. Almost all of them received consolidative radiotherapy, and they had an excellent outcome. So it's been our approach for those patients who have a Deauville score 4 to give these patients consolidative radiotherapy. Whether all of them do need consolidative radiotherapy is one question that we need to discriminate further. Unfortunately, those patients who have a Deauville score 5, who had a range of different therapies, who had second-line chemotherapy, consolidated with high-dose chemotherapy or radiotherapy, you can see that their outcomes, unfortunately, are much less good. What's very interesting with this study is also that we can go back to this question about what's the induction therapy. Now, this study was not powered to identify what the optimal induction therapy was, but this is the outcome at the end of treatment according to the induction therapy. And you can see that patients treated with R-CHOP21, 23% of patients had a Deauville score of 5 at the end of induction therapy, whilst those patients treated with R-CHOP14, VACOP or MACOP-B or dose-adjusted EPOCH, less than 10% of those patients had a Deauville score 5 at the end of induction therapy. So this gives us further weight to demonstrate that we shouldn't be using R-CHOP21 in this patient population, and therefore you can see the event-free survival curve of those patients treated with R-CHOP21 in the red compared with all the other regimen. So we certainly don't use R-CHOP21 in the UK in any of our patient populations with mediastinal lymphoma. Okay, so we've kind of moved towards where we think the optimal induction regimen is. What about that unfortunate group of patients that relapse or fail to achieve initial benefit? Unfortunately, these patients are really quite difficult to achieve initial reinduction therapy, and the response rates to reinduction therapy are perhaps lower in a number of retrospective series than conventional diffuse large B-cell lymphoma. However, if you do get to achieve a response and the patients are proven to be chemotherapy, they seem to benefit from high-dose chemotherapy and peripheral blood progenitor cell rescue to consolidate second or subsequent remission. And these are just examples of some retrospective series demonstrating the outcomes of patients who underwent autologous stem cell transplant in second and subsequent remission, demonstrating that about 50 to 60% of these patients can have long-term benefit, assuming they got to the point of high-dose chemotherapy, assuming that they've demonstrated sensitivity. What about some of the newer therapies for mediastinal lymphomas? Well, of course, I've said that CD30 is expressed upon the malignant cell. it tends to be weaker than expression in Hodgkin's lymphoma, and therefore, brentuximab vedotin, the antibody drug conjugate, would a sensible therapy to explore. However, the data with brentuximab vedotin has been really very disappointing, and in fact, the phase 2 trial in primary mediastinal lymphoma was stopped early due to lack of efficacy, with only 2 out of 15 patients responding. As I've said, that PD-L1 provides an excellent target in the interaction between the malignant B cell and the T cells, and has caused a lot of excitement in terms of the role of checkpoint inhibitors in treatment of relapsed and refractory diseases. In this small study of patients treated with pembrolizumab, responses were seen in about 50% of patients as a single agent with a duration of about 11 months. And I think this interesting data and this great science behind pembrolizumab has resulted in the development of a phase 3 trial that's been run out of the US by the Children's Group, looking at the addition of nivolumab to induction immunochemotherapy to see if we can enhance response rates. The combination of a checkpoint inhibitor and brentuximab vedotin has been reported in patients with Hodgkin's lymphoma. Little data in primary mediastinal lymphoma, but looks to be synergistic. And I think certainly for some people, the combination of nivo and brentuximab vedotin is attractive. However, the data set supporting that in PMBL is very low indeed. Now, of course, what about CAR T cell therapy? And I think this is really important innovation in the treatment of mediastinal lymphoma. However, the data is pretty limited. So in the pivotal ZUMA-1 study, only 8 patients with CAR T cell therapy had primary mediastinal lymphoma, and it's impossible to dissect out how much benefit there was. For Tisa-cel, or Tisagen, in the Juliet pivotal study, no patients were entered who had mediastinal lymphoma. And in the Transcend study, that was the pivotal study for Lysocell, of the patients entered, 14 of those had primary mediastinal lymphoma. And their response rates really mirrored the whole patient population set, with an overall response rate of 79% and 50% of patients achieving a CR in the third line setting. So some evidence for efficacy of CAR Ts in mediastinal lymphoma, but really very small data sets. So we've seen some real world outcome now, and this is important to help contextualize that data from the pivotal studies. So in the US, Axicell treated patients with primary mediastinal lymphoma from 5 US centers. This is a total of 33 patients, demonstrating an overall response rate of some 78%, with about 69% of patients achieving a complete remission. The 2-year progression-free survival and overall survival is 64% and 78% respectively. So I think outcomes really very similar to the expected data set for other large cell lymphomas. There are patients within this data set who have been previously treated with a checkpoint inhibitor, and that didn't appear to affect the response rates or the time to event analysis or the pattern of cytokine release syndrome or neurotoxicity. So I think the real world data confirms to us that we can safely deliver CAR T cell therapies for patients with primary mediastinal lymphoma safely and is associated with high response rates. Now, of course, the landscape for second line large cell lymphoma has changed significantly over the last year or 18 months or so for those patients who've had early relapse of disease. So we know that we've seen data to demonstrate the improved event-free survival and overall survival of Axicell and Lysocell in those patients who have an early relapse with less than 1 year after completion of R-CHOP chemotherapy, or have got primary failure. And we've seen this data of Axicell demonstrating a clear improvement in event-free survival. However, there were no patients who were entered into the ZUMA-7 study with primary mediastinal lymphoma. So we cannot use this data to approve or to support the use of CAR T-cell in the second-line setting with early relapse patients with primary mediastinal lymphoma. I will say, however, data from the Transform study that looked at liso-cel did include patients with primary mediastinal lymphoma, and there was a demonstration in event-free survival. But at present, liso-cel doesn't have that range of approvals, and we don't have the market penetration to be able to use this widely. What about the role of allogeneic transplantation in primary mediastinal lymphoma? Well, we can see from retrospective data, this is data from Alex Herrera from the City of Hope, demonstrating that in a highly selected small group of patients with PMBL, we can get long-term overall survival and progression-free survival. But this is a very small number of patients collected over a very large period of time. I think it's less than 30 patients in this series. So there is a limited role if you can get patients to the point of remission to benefit from allogeneic transplantation. So just a time, to end up really, where are we going in the future? Well, I certainly think that there's a clear role for ctDNA analysis in the role of primary mediastinal lymphoma, both in terms of response assessment and dynamic response assessment to determine quickly which patients are going to respond and which patients are not going to respond. And the other area where I see ctDNA of being clear value is in patients that have residual masses at the end of induction therapy, deciding whether that's a sterile mass or whether there's active lymphoma, looking to help enhance the question about the role of consolidative radiotherapy. Did all of those patients who had a Deauville score 4 at the end of induction therapy, did all of those patients need radiotherapy? So I think this is a great time for evolution of this disease, and we've learned so much about this over the last few years. So in summary, mediastinal lymphoma is a post-thymic germinal center B-cell lymphoma which has a unique pathophysiology. It has an excellent prognosis with modern therapy. Radiotherapy can be safely admitted in those patients who have who are PET negative after induction immunochemotherapy, and you should use an intensified chemotherapy regimen at induction, be that R-CHOP14, be that MACOP-VACOP-B, or be that dose-adjusted EPOCH. And of course, there's an emerging role for the novel therapies at the time of recurrence of the disease. Thank you so much for listening. I very much look forward to our discussions, as I'm sure some of you may have different opinions, but thanks very much.
Thank you, sir, for that wonderful talk. It was quite impressive, and what an update. Thank you, sir, for being over here. And we have some now Indian colleagues will discuss with you in the question association. So to start with, we have first Dr. Krishnaratan Kannan. Sir, please, your question, please.
Thank you, Professor Davis, for a lucid talk. Most of the questions have been already answered. Now, if you do a end of treatment PET and you find a Deauville score 4 or 5, would you do a biopsy, and is it be a challenge to do a biopsy?
So I think that's really important. So I think there are a lot of challenges about doing a biopsy. So yes, I would always try and strive to do a biopsy because I don't want false positive results from my PET scan. But I think at a Deauville score 5, it is quite a difficult call. You see significant uptake above the liver, and you see new areas when you've got a Deauville score 5. The trouble is with often you see fairly heterogeneous changes, and targeted biopsies can be quite difficult to deliver, and they can be in difficult anatomical situations. But I would always strive to do a biopsy before I offered an alternative therapy in this group of patients.
Yeah, just one more question. And if you have a relapse, can we just give checkpoint inhibitors and then take the patient for autologous transplant?
Oh, great question. And I think that this is interesting. I think if we take the lessons from Hodgkin's lymphoma, where I think I come from the school autologous transplant, you've got to demonstrate that you've got chemo sensitivity before you go to autologous stem cell transplantation, but we'll see the lessons from Hodgkin's lymphoma, recognizing that patients who have reinduction with a checkpoint inhibitor can have great outcomes with autologous stem cell transplantation. So there's no data to support that in primary mediastinal lymphoma, but for my mind, you can do that. And I think if you are fortunate enough to get a response, because I think the responses from reinduction chemotherapy are pretty disappointing. You saw that data that demonstrates that only about a third of patients do benefit from chemotherapy. So I think it's an entirely reasonable thing to think about reinduction with a checkpoint inhibitor and consolidate with stem cell transplantation.
Can we add a checkpoint inhibitor to chemotherapy combination?
Well, I mean, we know that that's a kind of a safe thing to do from the lessons from all the other tumors, but I haven't seen any data in mediastinal lymphoma to support that.
Thank you so much.
Thank you, sir. Dr. Rajan Yadav, your question, please.
Good morning, sir. Thank you so much. Whatever I had written down, you've already answered, so I'll come up with a new question. Is there any role of immune checkpoint inhibitors upfront in mediastinal lymphomas?
I think that's a really good question. I mean, I think that it would be great if we can add checkpoint inhibitors to chemotherapy, or we can do windows, kind of like, you know, the way the thinking is going with Hodgkin's lymphoma. We can potentially reduce the numbers of patients who are PET positive at the end of induction therapy and spare even more patients from radiotherapy now. As I say, at the moment, there is a randomized study that's going on in the US across children and young adults, asking the question, adding nivolumab to induction permissive chemotherapies to see if you can absolutely achieve that. So the jury is out at the moment in terms of there being no data, but we're actively trying to answer that question.
Thank you so much. Thank you so much, Professor.
Dr. Satyarupa Mahapatra, your question, please.
Thank you, sir, for your very concise and very clear lecture. So I wanted to ask, sir, is there any role of interim PET in our clinical practice in those with PMBCL?
So that's a really good question. And I think the answer to that is we don't quite know that yet. So whilst we were undertaking the ILSG study, we did collect interim PET scans. We haven't done that analysis yet to see the value of them, and I think I'm always cautious about the false positive rates in PET scanning in PMBL because we see, you know, very, as I say, heterogeneous uptake. So at the moment, it's nice to have an interim PET scan that demonstrates you're heading in the right direction and you've achieved benefit. What you do with a PET scan, an interim PET scan that's positive, I'm not so sure that we understand the predictive value of that yet, and whether that just frightens us and we shouldn't be rushing in to change therapies, etc. So I'm cautious about it. And to be quite honest, what I do is I don't generally do any interim imaging in these patients. I keep an eye on their chest X-ray to make sure that their cyto reducing during each cycle of treatment. And if I've got any doubt about that, I might do an interim CT scan to look for reduction, but actually I don't. And what I want to do is make sure I do that PET scan at the end of treatment. I don't want to do that PET scan too early because that's associated with false positive rates. So I do that 6 weeks after our induction immunochemotherapy. And that's, so 6 weeks seems to be a sweet spot in terms of not leaving it too long that the radiotherapy becomes difficult to deliver afterwards, but not doing it too early where you might get false positive rates. So basically, I don't know, we don't know yet the role of interim PET scan. Number one, don't overdo it during imaging, during treatment, and make sure you do your end of induction PET scan 6 weeks after your last cycle of chemotherapy.
That was very clear. Thank you, sir.
Thank you, Dr. Satyarupa. Dr. Prasanna, your question, please.
Thank you, Dr. Davis, for excellent presentation. I just have one question about polatuzumab. What is your experience with the polatuzumab in refractory mediastinal B-cell lymphomas? And the other question is, does polatuzumab have a role or a place when it comes to the first-line chemotherapy? Can it be added as any effort for response when it comes to the first-line therapy as well?
So I think that's a really important question, and lots of unknowns. So I will say to you that my limited experience with using polatuzumab, and I think pretty much everyone's got limited experience, and I don't think I know of any data series with polatuzumab in the relapse setting. It has been disappointing. I think remember that when we give polatuzumab in the relapse setting, generally we're giving it in combination with bendamustine, and bendamustine kind of really inhibits some of the cellular therapies that we might like to get to with these patients, or it might inhibit our stem cell collection or various things. So we've tended to avoid it, and so I don't think I've had particularly helpful experience with it. The question is, in the frontline setting, whether that can help you is a big second unknown. And the reason I say that is because, we'll be giving polatuzumab with R-CHOP 21. We don't want to give these patients R-CHOP 21 because we know there's an inferior induction regimen, and so we have no experience of giving polatuzumab with R-CHOP 14 or giving it with dose-adjusted EPOCH. And whilst you say, well, you might increase progression-free survival, we have no idea, and so I think that's an area for active exploration. So I think watch this space, but at the moment, and certainly I don't give these patients polatuzumab, and I can't see that there's any recommendation to do that.
Thank you. Thank you.
Thank you, Dr. Prasanna. Dr. Sushil Silvarajan, your question, please.
Thank you, Dr. Andy, for that illuminating talk. Just a question. I mean, because you covered PMBCL so extensively, I thought I'd ask you something on mediastinal gray zone. How do you manage mediastinal gray zone? I mean, in difference to PMBCL?
Oh, I think mediastinal gray zone lymphoma. So this is a rare disorder. This is difficult to diagnose, and it's full of challenges in terms of our therapeutic approaches. And I don't think anybody particularly knows how we should approach this. But essentially, I try and apply the same principles as we apply for primary mediastinal lymphoma, to be quite honest. So I like to use in this group of patients R-CHOP 21. If my pathologist tells me that this is much more towards Hodgkin's lymphoma in this sort of spectrum, and the clinicopathology is perhaps right, then I might treat it as a Hodgkin's lymphoma, but invariably I'm going to give them R-CHOP 21 and use the same principles in terms of the end of induction PET scan to make a decision about whether they should have consultative radiotherapy or not. But that's, nobody really knows how to optimally manage these group of patients yet.
Sure. Thanks. The reason I was asking is that we've got a whole bunch of patients where the diagnosis is nebulous, and so we usually err on the side of giving R-dosage EPOCH when it's a gray zone between these two. So.
And I think my preference for R-CHOP 21 is just based upon I don't use dose-adjusted EPOCH in primary mediastinal lymphoma. I use that, in other indications, but not in primary mediastinal lymphoma. I don't like to use it because of the dose intensification, and the fact that these patients are going to do really well in the long term, and that very few patients with R-CHOP 14 need to end up having radiotherapy. But I do recognise that many people do like to use dose-adjusted EPOCH based upon the NCI data. So that's why I use R-CHOP 14, because I would use that in a PMBL case. But our tumour boards, we agonise over how to best approach these patients, and I think it's really interesting to hear different people's perspective on it.
Thank you so much.
Thank you, Dr. Sushil. Dr. Ashok Mishra, your question, please.
Thank you, sir. Thank you for a very elaborative presentation on primary mediastinal lymphoma. So my question is regarding JAK2 inhibitors like ruxolitinib, their role in treatment of primary mediastinal lymphomas.
Yeah, I think that that there has been some interest in using that, and I think that ruxolitinib, but there has been very little prospective data, and I think there's been some. I'm not even sure if it has been reported or not. I think there's been some small numbers of test cases. Basically, it's been the story of anecdote rather than any pre-planned study. We did talk about this some years ago, whether it was something that we're going to do, but I'm not aware of any proper series that have been reported. And I think, although I've said to you that JAK2 aberration and aberrations in the JAK2 pathway are JAK-STAT pathway are important in the pathophysiology, there's very much more to it than simply JAK2 activation. So I think targeting a single pathway aberration is probably going to be insufficient in our patients. But I think it's really an interesting drug that one might perhaps look at in combination.
Thank you very much, sir.
Thank you, Dr. Ashok Mishram. Dr. Krishnatharan, your question, please.
Thank you again for the second round. When you use R-CHOP 14, are you able to deliver the chemotherapy in time or use growth factors?
Yeah, so we use growth factors to do that. No problem at all to deliver therapy. It's very well tolerated by patients. I will say that fatigue towards the end of the 6 cycles can be challenging. Normally patients, for example, when you give R-CHOP 21, they have a terrible 2 weeks, then they have a week where they feel good and they feel human and they thank you for it. With R-CHOP 14, of course, the turnaround time is very quick. So as we keep the neutrophil count up. The difference with neutropenic sepsis rate between 14 and 21 is no different. There's a bit more thrombocytopenia, but normally you can recover very quickly. And of course, this means you get treatment over in 12 weeks, which is much better than the kind of 3 months of having a 3-weekly regimen. But it does require growth product support, growth factor support.
Thank you so much.
Thank you, sir. Dr. Gopinathan, your question.
Good morning, sir. Thanks for the very elaborative lecture. Sir, what would be your approach in primary chemo-refractory PMBCs and use of small molecules like ibrutinib along with some other salvage like ICE? Would it make any difference?
Okay, so my approach for refractory disease is based upon, unfortunately, a little bit about the approvals that we have in the UK and the access that we have in the UK, and I don't quite have the spectrum of drugs that I perhaps would like to have. So for reinduction, I would offer these patients chemotherapy, and a combination of ICE chemotherapy is my standard, or GDP chemotherapy. Unfortunately, I don't have any drugs that I can add to that to be able to use. And if patients respond, to go on and consolidate that with high-dose chemotherapy and stem cell rescue. If that doesn't work, they fail to respond to induction therapy, then in the 3rd-line setting, based upon the ZUMA-1 data, I'm allowed to use CAR T-cell therapy, but not until the 3rd-line setting. Unfortunately, I do not have any access to checkpoint inhibitors in the UK for PMBL because there's no approvals, and I don't have access to brentuximab vedotin to use in combination with a checkpoint inhibitor. I don't have any small molecules that we can use, all of which are very, very frustrating. So although we can kind of talk about some of these novel approaches, that's not accessible for all patients. But we have, on patients who have been able to fund themselves, we've used checkpoint inhibitors with great success, but unfortunately the quality of the data hasn't made it past the NICE hurdle that we have in the UK, and therefore it's chemotherapy for 2nd-line therapy, and for 3rd-line it's Axicel.
Thank you, sir.
Thank you, Dr. Gopinathan. Dr. Karunakaran, your question, please.
Yes, sir. So basically, we are looking at the multicentric retrospective data from India, and what we've seen is that there are quite a few patients who have been treated with R-CHOP, and a significant number of patients who are on DR EPOCH regimen, and many of them actually receive radiation consolidation RT even after DR EPOCH. But from the outcomes point of view, we find that our outcomes are much inferior to the Dunleavy data. We are going to present this data in the upcoming ASH meeting. So one of the things that came to mind is that our patients seem to have a lot of intra-abdominal disease, intra-diaphragmatic disease, like pancreatic lesions and all that. we were just contemplating whether this could be a kind of a marker of a delayed presentation to the hospital, and that is kind of contributing to a poorer outcome. Would you have any thoughts on that, sir, as to why our patients have a poorer outcome compared to the Western data?
Yeah, I mean, I think that's very interesting. So I think that without being try not to be critical, I think that the patients who are in the NCI study were the better risk end of a population of PMBL patients. So, as you say, if you go to the NCI, you want to be on a clinical trial, that they need to see people who want to be on a clinical trial. So there are patients who are well enough to have had a diagnosis of PMBL and then have got themselves to the National Cancer Institute in Washington and then presented and had enough time to get themselves onto a clinical trial. Now that's completely different, I think, from the patients that we might see in our practice who turn up with these big mediastinal masses and superior vena cava obstruction and who are very unwell, etc. So I think that you're seeing a different spectrum, and you've seen from a number of retrospective series that I presented during my presentation that the outcomes are not as good as the outcomes that have been seen with the patients presented at the NCI. I think how you describe patients with extra thoracic disease and extranodal sites and potential late presentation is simply a reflection of that, and they're going to therefore be higher risk patients. So I think that's exactly why your outcomes are nowhere near as good. What's very interesting is also in the retrospective series, although there was no radiotherapy given to patients in the NCI study, all these retrospective series have given radiotherapy to quite a lot of the patients treated with dose-adjusted EPOCH. And as I say, many of the patients aren't getting escalation. It's quite, when you give dose-adjusted EPOCH, isn't it? It's quite involved to do that. You're monitoring the blood count twice a week, you're chasing down the blood count, you're trying to modify the dose and escalate or de-escalate the dose. So it's quite an involved process. And actually what we can see in the real world is that patients, maybe to do with fitness, maybe to do with the operational factors around delivery, are in no way being escalated like they had been done in the NCI study. So I think there are a number of factors, but I suspect you're absolutely right. You're seeing a profile of presentation that is much delayed and very different to those fit patients who went to the NCI.
Thank you.
Thank you, Dr. Parathan. So we have some few questions from the audience. It's almost repeat questions. Dr. Nikhil wants to know, there are many primary mediastinal B-cell lymphoma who are inadequately treated and referred to the tertiary centers with residual disease. Some of them are given just 4 cycles of R-CHOP. Some of them are given just 4 cycles of R-CVP. How would you approach this case who come to you with residual disease, inadequately treated with just 4 cycles of R-CHOP, 4 cycles of R-CVP? That is the first question. And would you consider now these patients to be on dose-adjusted R-EPOCH or some checkpoint inhibitors upfront?
Really difficult. And I think that I would want to consider, rather than making a general blanket statement about how to treat these patients, I think there are very many factors regarding these patients to make the decision, and that's what the PET scan looks like, how much residual disease there is, how much treatment they had beforehand, what was the reason. Was it just because it was considered to be low stage disease and hadn't been properly diagnosed as mediastinal lymphoma? So I think there's quite a lot of things to consider. The time from the last chemotherapy to when they were seen by you. I would be cautious in a patient who's been treated with R-CHOP to be then suddenly switch over to giving dose-adjusted EPOCH because of the cumulative anthracycline dose, and I might well give those patients a couple of rounds of ICE with consolidative radiotherapy. For those patients who've had CVP, then I think it's perfectly reasonable to switch over to an anthracycline-containing regimen. Dose-adjusted EPOCH looks good to me because, of course, you add a top side as well. So I think there's quite a lot of factors, and I think you have to consider that as a one-by-one basis. But I think what we need to do is get the message out to our referring sites about how to properly treat this disorder, and to get, as I say, I really strongly believe that you have excellent outcomes if you get your frontline therapy right, and that trying to to rescue patients is really problematic and fraught with difficulty.
Thank you, sir. And any role of transplant if these patients do come up and then you start with any of these therapies, should we go for transplant after that?
Yes, I mean, I think we've talked about that before. I think that if in second remission you get patient to benefit, to benefit, be that via chemotherapy or via that checkpoint inhibitor, if you've got that available, then I do think these patients need to have consolidation with high-dose chemotherapy and stem cell rescue. Absolutely. The role of allogeneic stem cell transplantation, I think for me now, has only been in patients who've relapsed post-CAR T cell therapy, where you can achieve another response, and we've done that a couple of times, but again, it is quite difficult. But I think the role of allo transplantation in the CAR T cell era is pretty limited.
Thank you, sir. Another question from Dr. Nikhil. What would be your salvage therapy of choice in a relapse setting?
Okay, so there's no data to guide that really, and my salvage therapy of choice would be ICE or GDP. That's because I know that we get good response rates, they're safe to deliver, they don't compromise the collection of peripheral blood progenitor cells. As I say, some sites in the US I know are using BV and nivolumab for induction. I don't have any access to that. I don't think the data is very good either. I think there's no data, even though there's data in Hodgkin's lymphoma. So I would use the chemotherapy regimen, and one of those. I think use any regimen that you are familiar with using for other large cell lymphomas.
Thank you, sir. Another question is, what is the role of pre-autologous stem cell transplant radiotherapy in relapse setting?
So I don't like to offer radiotherapy prior to autologous stem cell. I find that I like to demonstrate use responsiveness with whatever induction regimen I'm giving, and then consolidate with high-dose therapy, and then to consider consolidation with radiotherapy afterwards for those patients. There's no data to say whether they should be, you should only give the data post autologous transplantation to PET positive or PET negative. I think that if you've had disease that's refractory, you should consolidate all these patients post autograft with radiotherapy. I don't use it beforehand because I think it adds significantly to the toxicity because of the carmustine and the lomustine. So I want to try and avoid pre-autologous transplantation radiotherapy and leave it until afterwards.
Thank you so much, sir. Another question from Dr. Nikhil once again. Any comparative study between R-CHOP14 and dose-adjusted R-EPOCH in terms of long-term safety outcomes and efficacy?
Great question, really important. Simple answer, no. So we have only retrospective data that looks at the outcomes with R-CHOP14 compared with dose-adjusted EPOCH. There's not very much with that, and we know from the ILS-G37, so our large prospective study, that's a bit of prospective data, but not powered to look at the difference between the different induction regimens. It was just an investigator choice. So we don't know about that. What we are certainly going to do in the ILS-G37 study is we can continue to look after these patients long term, and they're all going to be assessed at 10 years to look at some of those important safety issues. And so therefore we'll be able to potentially report on that in the future.
Thank you, sir. Dr. Sushil Selvarajan, do you have any other question? Okay, so any discussions wants to ask any question to Dr. Andrew? Because I finished all the questions from the audience. Well, sir, there are, Dr. Krishnathan Karan.
Just for quick question for Devil score 4, do you just go for radiotherapy or is there any need to do a biopsy?
Yeah, good question. Yeah, so I for patients with Devil score 4, we give them all just radiotherapy. Okay, we don't try and do a biopsy first of all. I think there's something important in your question, and it may well be that we might be over treating patients, and not everybody might not need radiotherapy. But I think biopsies in this group of patients are difficult. It's difficult to make sure that because of the heterogeneous uptake on the PET scan, you might not get an area of PET avidity, so you might find yourself falsely being reassured that you have an area of PET, of negativity. What I would like to do is us to be able to use in the future things like ctDNA to help guide us to know whether a Deauville score is truly got evidence of active disease. But what we saw from the ILS-G37 study was that if you were Deauville score 4, almost all of those had radiotherapy, and all of those had really excellent outcome, the same as if you were PET negative. So for that reason, my strategy is not to biopsy, give everybody radiotherapy. And I appreciate I might be over treating everybody, but at the moment, I don't have a better way of discriminating them.
Thank you.
Thank you, Dr. Krishnanathanam. Any other question from any discussions? Well, so I finished all the questions from the audience, and there are no more raising signs. Sir, you were fantastic, fabulous, and what an update on mediastinal large B-cell lymphoma. Many things we learned from you, and really, it was a great learning for all of us. Thank you, sir, for being over here this Sunday, a very early morning for you, and sparing your time today. Thank you so much.
It's been a great pleasure. Thank you very much. I've enjoyed it.
Thank you, sir. And thank you. I thank all the discussants to join here and all the audiences to join over here this Sunday. Meet you next week, again Saturday, Sunday, with the next best webinars and beautiful webinars. Till then, goodbye to everybody of you. Thank you, sir. Thank you once again for joining us on board. It was a pleasure having you on board, sir, today. Thank you, sir.
Thank you.